On today's episode, Nick is going to set me up for some real trouble. Apparently, Eric Topol said some stuff about Peter Attia, which was on social media. We're going to sit here and I guess watch the video and then see how I react.
Anybody who's selling supplements has lost their credibility.
Stop right there. I agree, 100%. What he just said. Totally.
I don't know what to make with that data.
Okay, let's stop for a second right there. Again, that's misinformation.
Yeah. And then, of course, now
Stop. Just stop, right?
I guess one quick thing I want to say is I think you, Eric, Peter, and Dr. Mike, whose YouTube channel this is on, agree on 95% of things.
Yeah.
So I just highlighted 5% that I thought would be fun to get your reaction on.
I actually think that's a really important point to make, is because sometimes the areas of disagreement get blown out of proportion compared to the areas of agreement. And again, I think, I can't say it enough. Tons of respect for both of these guys. So where I criticize either of them, it's not coming from any place other than a difference of opinion, or in some cases, we all make mistakes when we get outside of our direct area of expertise.
I think that anybody who's selling supplements, who calls himself a longevity, scientist or expert, has lost their credibility. Because there's no
Stop right there. I agree, 100%. What he just said, totally. I'm not sure why they showed a picture of Peter there. Number one, Peter doesn't call himself a longevity scientist, as far as I know. And number two, I don't think he's selling any supplements directly. He may have advisory relationships with companies that are selling supplements, but I don't think he's directly selling supplements. There are certainly other people in the space that Topol could have called out, if that was his intention, than Peter Attia. There are practicing research scientists at academic institutions selling longevity supplements. To me, that's a whole different level than anything that Peter Attia is doing. But I agree completely with what he just said. In fact, I agree so much, let's go back and play it again.
Great. Yeah. And quick thing to add is this is just the 1 minute intro. We'll get into the full thing. This is just Dr. Mike trying to hook you, which it looks like he's doing a good job.
I think that anybody who's selling supplements, who calls himself a longevity, scientist or expert, has lost their credibility. Because there's no supplements that have been shown to reverse aging, slow aging. It's a totally unregulated jungleoid space. And unfortunately, he's one of the people that are doing this now.
Longevity clinics are selling $2,000 life-saving full-body MRIs. TikTok influencers hawk glucose monitors to people without diabetes, and best-selling authors are pushing supplements to prolong life, all with zero real evidence.
So I'm sure we'll dive into this, but again, I think this is a bit of misinformation putting diagnostics, preventative diagnostics, in the same bucket as supplements. Now, I think we can have a legitimate conversation about whether whole body MRI or continuous glucose monitoring is right for everybody in a preventative sense. But certainly those things work, right? So I think it's a question. It's misinformation to lump those together, because we have no idea if the supplements do anything valuable. We know for sure that these diagnostics do what they're designed to do, right? Which is detect disease, measure metabolites, things like that. So intellectually dishonest to do what he just did.
After watching the whole video and hearing this again, the supplement he's referred to I actually think is Rapamycin, because they talk about that with
Well, that's not a supplement. So if they're talking about that as a supplement, again, that's misinformation.
Yeah.
That is a prescribed medication by a medical professional.
Yeah, so we'll get there, but
To unpack
that's
what the
what it
data
seems like.
actually shows, I'm joined on this episode by Dr. Eric Topol, world-renowned cardiologist, researcher, and founder of the Scripps Research Translational Institute. He's the author of the new book, Superagers, which takes an evidence-based look at the science behind living longer. It's not bells and whistles. This is the real science that will help you age gracefully. In this episode, we'll discuss aging, the hucksters capitalizing on your fear of aging, as well as what innovations we can expect to see from AI within our lifetimes. Without further ado, please welcome Dr. Eric Topol to the Checkup Podcast.
Expensive.
Yeah.
So I don't accept that, and I want hard evidence. And some of the doctors that are so-called longevity experts, authors, they are promoting this. Yeah. There are companies they call themselves longevity companies. They say part of your being a member is you get a discounted total body MRI. This is terrible.
How do you feel about...
So stop a second there. Again, we didn't watch the whole thing, but this is what I was talking about before, where I feel like Topol comes from a little bit of a medicine 2.0 culture. He has been trained in the reactive disease care industry to wait until people are sick before doing anything about it in general. And again, that's an oversimplification. I know he talks a lot about preventative care, but I think it's just a different perspective, right? I'm not a trained MD. I was never indoctrinated into that culture. And my perspective is things like whole body MRI do have value for some people to detect problems early. Again, it's a legitimate conversation to have around who should get it, how broadly should these things be made available. Obviously, they're expensive right now, so there's discrepancies in who can even get access to them. But to kind of blanket state it's terrible that these clinics are doing this is just nonsense. And I think, again, he probably will never listen to this, but if he does, I would encourage Dr. Topol to maybe take a step back and evaluate in a more unbiased way who might these things be useful for? Because it's not terrible that clinics are making these available to people. Sure, it may be that some of the clinics are over prescribing, over recommending. That's a different conversation, but that's also an opinion, right? I don't think there's hard data one way or the other to say absolutely giving everybody a whole body MRI would be worse than giving nobody a whole body MRI. And what he's advocating for is nobody should get a whole body MRI as preventative care. At least that's what it sounded like here.
Yep. And as always, anybody you react to is welcome on the podcast.
Of course.
Yeah,
I would be happy to have either of these guys on the podcast.
I'd love to see you on Dr. Mike's podcast. So.
Promoting the stand-up MRI, full body MRIs, when in the past, perhaps you've praised some of those individuals. I know like Peter Attia was someone whose work you've admired. What's your take on him discussing topics like the MRI, rapamycin, et cetera?
Yeah, so I challenged him. I have a much smaller podcast, Ground Truths, where I write newsletters or interview. And I had done a review of his book where I said there were a lot of good things, but there also were a lot of bad things. And one of them was the total body MRI. There was rapamycin. There was an overdose for protein that was advocated, and many other things.
Let's stop for a second there.
I invited him.
So again, this is where I think he's probably just saying it this way for clicks, but an overdose of protein, first of all, I'm sorry, there is absolutely no evidence that what Peter has recommended in terms of protein intake is an overdose. We actually don't know what the right concentration of protein is or the optimal concentration of protein is for different people. So again, it sounds as if Topol is making claims with certainty that nobody really knows the answer to. And that's, I think, problematic when people who have a large following do that.
Mm. And if I remember correctly, in the book, Peter recommends around 1 gram per pound of body weight on the upper end.
I don't remember exactly what Peter's recommendation is, but you'll I mean, again, and knowing Peter, I very much suspect it was not, this is what everybody should do.
It's a range, it's nuance.
And when I was on Peter's podcast, we did a deep dive on protein. It's a complicated topic. There is no right answer. We honestly don't know at the population level what the right recommendation for protein is to optimize either longevity or health span. Hopefully those will go together. And it's very dependent on an individual's age, the diet that they're eating. So the amount of protein you eat has a different effect on your health if you're eating a high quality diet and you are not overeating versus if you are eating a low quality diet and you are overeating, right? The effects of high protein or low protein in those contexts are very different. So sort of blanket statements that Peter is recommending, an overdose of protein is just silly. Again, it might be for clicks, but I would hope that somebody of Dr. Topol's stature would be more precise and careful in his language.
Okay. And I think because he's a cardiologist, he's coming from a background of increased protein meats, increased perhaps animal meats or eggs, which could affect.
But it doesn't, obviously.
saturated.
Again, he knows this, right? So this is where I think people just need to be precise in their language.
Mm-hmm. Absolutely. And just one quick reminder. So for biochemistry, really all that separates protein and carbs is nitrogen, right? So if you have too much protein, you're not going to overdose. If you have healthy kidneys, you'll just gluconeogenesis, you'll turn it into
Well, it's more complicated than that because the effect of protein on your entire metabolic state, right, is different than, so from the chemical structure, sure, but the effect of eating protein versus eating carbs versus eating fat on your overall metabolic state is very different, independent of their chemical structure. And as I was alluding to, it's very dependent on your sort of total lifestyle and environment at whole, but lifestyle in particular and diet in particular. Just to give a very specific example, if you are eating a low quality diet, meaning, lots of ultra processed foods, lots of simple sugars, and you are eating an overabundance of calories, right? So you're in calorie excess, you're gaining weight, you're obese, you're metabolically challenged. If you put high protein on top of that, it's very likely you're going to be at a greater risk of both heart disease and cancer. If you eat that same amount of protein, but you are eating a high quality diet and you are not overfed, maybe even in a calorie deficit, you're losing weight, those risks are essentially zero. So the context matters so much here that, again, blanket statements around protein are just incorrect.
Invited him, and of course, it's hard to get to Peter.
Well, Eric, I'm easy. I would be happy to come on your podcast.
His people. Finally, he agreed to do it because he knew I had some questions for him. And he is, very strong about his views and how, it's good to take rapamycin. When I challenged him that this is an immunosuppressant, it's very potent, it's different for every person. And also, there's this rapamycin leaderboard where all these people are taking different doses once a day, once a week. Nobody knows the dose. And there are no data in people that it's either safe or that it promotes.
Okay, let's stop right there. So again, this is where I assume he knows this and he's just misstating the situation. Although if he doesn't know this, that's a problem because he really should know this. There's a lot of data in people on safety. It's FDA approved, number one. So clearly it has passed their safety standards, even in organ transplant patients. And among the people who are using rapamycin off-label, there's now a very large body of data, including data that we have published in the peer-reviewed literature. So to say that there's no data on safety is just wrong. Again, it's like stupid wrong. Sorry, but it is. Now, he's true that we don't have data that it promotes healthy aging or lifespan extension in people, or at least much data. I think there are some indications that off-label use of rapamycin can have potential benefits in people, but we certainly don't have randomized double-blind placebo-controlled clinical trials. So that part is true. I don't think Peter has ever advocated that everyone should be taking rapamycin. In fact, I'm quite sure that he says that only a minority of his patients takes rapamycin. So again, presenting this as if Peter's saying everyone should take rapamycin and there's no data, both of those things are wrong.
Yeah, absolutely. Oh, I think he misspoke when he said leaderboard. Brian Johnson has his biological age test leaderboard. I think he's talking about Krister's leaderboard, which has nothing to do with Peter, nothing to do with me. It's not really a leaderboard. It's just a table that he updates periodically where he puts what people who are sort of known in the space have said that they're doing. And we don't even know if that's accurate, right? People say they're doing things. Are they actually doing that? I don't know. But he does have a table basically that lists different people and what they have publicly said they are doing with respect to rapamycin use off-label. And that's just to help find the right dose that might be right for you if you're kind of doing it off traditional label.
I suspect that what bothers Dr. Topol about that leaderboard or table or whatever is it, and he does have, there's some validity to this view. It's out there publicly and it makes it seem as though this is something that all the well-known, respected people are doing, and it's a cool thing to do, and everybody should be doing it. So that probably bothers him a little bit. I don't think that's Krister's intention, just like it's not my intention when I talk about rapamycin and my experiences with rapamycin to say that everybody should start taking rapamycin. So if that's the way people are interpreting it, I understand why that might bother people like Dr. Topol who are more conservative and don't think people should be taking rapamycin off label. Again, I have a strong difference of opinion with him. And I would say it seems clear to me that I know the data here much better than he does.
Yeah, great. So it's not like a arcade leaderboard where the highest dose is at the top and the lowest inflammation. Or
No. And there's no reason to think that taking as much rapamycin as you possibly can is the right thing to do.
Exactly.
Right.
Yeah.
Healthy aging or slows aging or anything. So he, of course, is kind of like what you got from the Pronovo CEO. Well, I don't want to wait 10 years. I kind of have a hunch, and I want to practice medicine, based on my best. Well, I don't buy it. I admire
So stop for a
Peter
second. So again, this is where I think it's just a cultural difference. Reactive disease care, proactive healthcare, right? And again, I know Dr. Topol isn't like a totally reactive disease care guy, but that's the mindset here, right? So wait 10 years. I don't want to wait 10 years. The reality is we're not going to know in 10 years. We had pretty good reason to believe rapamycin could possibly slow aging in people 10 years ago. Nobody's done the definitive clinical trials because nobody's paying for it. We could wait another 10 years. We're probably not going to know because nobody's doing the definitive clinical trials. Nobody's paying for it. So it's not as though let's just wait until we get the data. There's no reason to believe we're actually going to get that data. So you have to make, I think, a risk reward calculation in the moment. As we get more data, that risk reward can change on whether or not you want to take rapamycin or do anything else. Right? Again, I think you can apply exactly this same logic to a particular diet or a particular nutritional strategy. You still have to guess. We still don't know what the best diet is, right? I think we know kind of macro level, and I don't mean macros, carbs, fats, but I mean at the high level, we know more or less what's a healthy diet, right? But for you personally or me personally, we don't know what the best diet is. You have to kind of take the best guess you've got with the data that you've got. I put rapamycin in that same sort of framework. So to suggest that it is somehow irresponsible to be looking at all of the data and concluding that for a subset of people, the risk reward favors reward. Like, I think legitimate disagreements of opinion, sure. To kind of dismiss people because they disagree with you, though, that's just, that's not scientific.
Yeah, I recently did Peter Diaz's early medical online sort of module, and the cancer section opens up with a long video of him explaining risk reward, the pros and cons, because he knows he's speaking to thousands of people, so you can't just say everyone get MRI, everyone don't get MRI.
Right.
He teaches you the nuance first, and then from there you use that to figure out if you need it.
Like his sections in his book on metabolic syndrome are excellent, but then there's so many things where he just jumps ahead, which I would challenge. He recommends that people take a gram of protein a day to eat. That's a huge amount.
I think he means a gram per pound
body weight.
Per body weight. I'm sorry, per pound of body weight per day. So a person that weighs 160, which is lightweight, would be 160 grams of protein a day. No, but
okay, stop. So again, this is where. Maybe he's just not trained in science. He's I know he publishes papers, but when I hear people say this, I'm just like, do you understand the idea of hypotheses that haven't been proven yet? He just dismisses the idea that 1 gram per pound of body weight of protein per day is acceptable, let alone optimal. He's like, no, like, come on. That's not the way a scientist thinks. You don't just dismiss something because you sort of have a feeling that that's not right. Yeah. As far as I know, there is no compelling data that I'm aware of that 1 gram of protein per pound of body weight is wrong, which is what he just said definitively. He's like, no, show me the data, guy. Come on. In fact, I think you could make a case that that's not an unreasonable range to be in. I sort of, again, gravitate towards somewhere between 0.6 and 1 gram of protein per pound of body weight a day. And that has to be in the context of an overall high quality diet. I think if you're eating a high quality diet, if you're getting up close to 1 gram of protein per pound of body weight a day, you will probably find that you are fully satiated. You're not hungry. You're not inclined to overeat. Your body composition, if you're working out, is going to be where you want it to be. Like, I think all those are good things. I don't understand where he's coming from. Just say no, right? Context matters here.
Because, thousands of people are watching this, and who's your audience? Is it a bodybuilder or is it someone with a kidney issue? Because their doses are going to be different, right?
Sure, but even there, I mean, yes, I think in people who have chronic kidney disease, obviously you want to watch out for a protein overload, right? Excess protein negatively impacting kidney function. Even there, I'm guessing it would be stratified by individuals. Not everybody who has chronic kidney disease is going to run into problems if they're up towards the higher end of protein intake. But of course, you want to be measuring that and tracking progression of the kidney disease. Again, I just want to keep coming back to this idea. I really believe that quality of diet matters, and maybe even matters more, probably matters much more than the amount of protein that you're getting, as long as you're within a reasonable protein range. And of course, you also need to be doing exercise, right? So all of these things go together.
Half of that is kind of where we're at for older adults, where it's shown to help maybe even some muscle mass. But, we go
You also got to
beyond
be
that.
careful of kidney disease, et cetera.
Yeah, again,
Yes. And then, of course, now we know
stop.
that.
Just stop, right? Okay, yes. If somebody has kidney disease, yes. I don't know of any evidence that 1 gram of protein per pound of body weight causes kidney disease in people, right? So
Very high levels of protein intake will promote atherosclerosis.
in the
promotes
context of a
inflammation,
low-quality
particularly with
diet.
animal protein. And then, there's several other things that he kind of goes off the track where there's no data. There's just no evidence. It's his beliefs. Now, he's entitled to his beliefs, and apparently, he has a pretty big following, but now he has a company that he's promoting longevity, and he's selling supplements. And I basically
So we should check. I don't know what he's talking about there. Do you? I don't know. I mean, maybe Peter has a company selling supplements. I'm not aware.
I think this whole thing they're referring to Athletic Greens, which is an advisory.
Okay,
Yeah.
got it.
he wasn't doing that at the time of the book. I think that anybody who's selling supplements, who calls himself a longevity, scientist or expert, has lost their credibility, because there's no supplements that have been shown to reverse aging, slow aging, promote healthy aging. Even though there's lots of claims, it's a totally unregulated jungleoid space, and unfortunately,
So let's stop. So again, without that last bit, and unfortunately, he's one of the people, because I'm not aware of any evidence Peter's selling supplements. If he is, then I will absolutely criticize the hell out of him for that. But this is one area where I am in 100% agreement with Dr. Topol. There is no evidence that any supplement slows aging, increases lifespan, improves health span in people, or at least no direct evidence, right? So again, we can point to animal studies for sure in a few cases where supplement active molecules have been shown or reported to extend lifespan. Usually those turn out to be not reproducible, so it becomes a question of, who do you believe? But there's really nothing that I would put in the category of convincing data for health span or longevity benefits in people. And I love that jungleoid. He's absolutely right. The consumer-facing supplement marketplace is just a shit show. It's unbelievably terrible. I'll say more about this in future podcast episodes, I'm sure. But that to me is the most problematic space in the longevity field right now, because the incentives are all driving people towards dishonesty, misleading marketing, and selling people products that probably don't work and may actually be harmful. What I will say is, I know a lot of people, maybe not a lot, I know some people who I respect as scientists who have gone into the supplement business, and without exception, they end up doing things that, in my view, destroy their credibility because the incentives push people to go that direction. In order to be competitive, you have to carry out deceptive marketing. You have to step way outside of what the actual data is telling you and make claims that are not supported by the data, because that's the way the industry works. That's a lack of regulation. And so, I don't want to demonize individuals, but as an industry, it's really, really, I think, harmful to a lot of people. And in fact, I've come to the conclusion that most people should probably just do a supplement detox. So just stop everything, unless your doctor has prescribed it to you, just stop. See how you feel. Give yourself a month. I bet you're not going to notice any difference. I think this is just smoke and mirrors, largely.
Interesting. Do you view supplements and pharmaceuticals both as just like different levers and tools in a tool belt, and you might you do a mix, right? So it kind of depends on what you're trying to optimize for. Versus there's people we know that are only supplements, there's people we know that are only pharmaceuticals.
That's just I think if you fall into the camp that I'm not going to take a drug, I'm only going to take supplements, or vice versa, that's just kind of based on a misunderstanding of biology, right? These are all bioactive molecules. Yeah. Generally, pharmaceuticals are going to have higher potency because that's what they're designed for. The other difference is, of course, pharmaceuticals will be required to go through relatively stringent safety and efficacy testing in order to get to market. That's why they're so expensive, right? Supplements aren't. Supplements, as long as there's no evidence that it's really harmful, you can basically get a generally recognized as safe designation if you fill out the paperwork and go to market until you find out it's not safe, and then it won't be allowed to be sold on market anymore. So it's just a completely different path. But they're all bioactive molecules. And I know there's this confusion around natural products versus, synthesized products. Look, guys, rapamycin's a natural product. It's produced by a bacteria on Easter Island. That's where it came from. So that, again, is sort of a misconception. Even molecules that are in our bodies can be classified as drugs and go through the FDA regulatory process. So it doesn't have anything to do with whether it's in nature. There's this misconception that, well, if it's in nature, it can't be bad. I mean, come on, there's all sorts of poisons out there in nature that are bad for you. Yeah. So I think there's just a lot of misunderstandings around, what a supplement is, what a pharmaceutical medication is, and how they're regulated by FDA. But sort of my overarching point is that I think a lot of people have been tricked by marketing to believe, number one, that all these supplements have value. They get sort of overwhelmed. I mean, I get overwhelmed with all the noise in the supplement space. You go to the grocery store, there are aisles of supplements, right? Like, I mean, come on. What are you going to do? Take all of them?
Yeah.
So how do you pick and choose? And it seems to be just a mishmash of, well, my friend told me I should take this, or, my wife takes this, or I heard such and such influencer talking about this supplement. It's not a science-based, evidence-based approach to deciding what to take, which is why I say the vast majority of the stuff does nothing. You're just going to pee it out in most cases. And of the stuff that does something, I think more often than not, it's going to be detrimental than beneficial. So unless you have taken a really, really solid look at the evidence for every supplement you're taking, or you have a deficiency, your doctor prescribed for you to take this supplement, my advice would be just stop. And then thoughtfully add back in if you're going to. I take very little. In fact, I'm down to, I take vitamin D a couple times a week, take omega-3 a couple times a week, I take a multi a few times a week. That's it. Yeah. And a creatine. So I started back on creatine. I do think the data on creatine is pretty intriguing, and there's very little reason to think there's a downside.
Yeah.
That's it.
I think we're overdue for a full supplement episode.
But I think I just said the answer. Just cut it all out. There's nothing that rises to the level, in my view, that everybody should be taking it. And I think there are some there's some gray areas. There's some stuff around, supplements where there is, again, probably very little downside, and maybe a lot of people have a deficiency, and again, for individuals, there are people who are going to have B12 deficiencies, things like that. Magnesium, I think, is another one you could put in that bucket. But so you could try it and see if you feel better. But I don't think I would just take it because it's just the latest fad in the influencer crowd.
Yeah, one thing I want to share, I think, with you and the audience is I worked at GNC for 5 years, and I saw the cat and mouse game of supplement comes out with a pro-hormone. It works. It sells a lot of it. 3 months later, it's banned. And then they take the pro-hormone and they add a methylated group. They change it a little bit. Then they put it back on the market, and it just repeats. And so the stuff that actually works usually gets banned after a few months. So.
Yeah, and again, I mean, obviously I'm coming down pretty hard on supplements, but this is really something I've been thinking about a lot. And you just can't get away from all the misleading advertising that's out there, which I think adds to this. So maybe I'm going too far the other direction, but again, I can't really think of very many cases where there's a strong evidence-based data set to support recommending, broadly speaking, that everybody should take supplement X. It just isn't out there. And so then you really have to ask why. Why do people take these things? If it's not because of evidence, it's because of marketing, right? You've been tricked into believing that this is going to help you.
Yeah. All right.
He's one of the people that are doing this now.
Yeah, I see this pattern evolve quite often where you have someone who's very interested in pursuing the future of healthcare, and they hurdle over many of the important steps that you need in order to validate research, to understand if it works on a broad scale between interperson variability, between safety with other medications. And all those things are bypassed in the name of trying to get further. But as we've seen historically with healthcare, not even just with the last 20 years, but 100 years, there were things that expert opinion drove us into the direction that was very dangerous.
Oh, yeah.
And that goes for something as wild as bloodletting or very extreme instances.
No, totally. And I think you have to put the body of evidence together. What do we know? What don't we know? And, what do we need to research to find if there's compelling evidence? And if you take that hard stance, I think you're on terra firma. And we just need to do more of that. But unfortunately, if you go across the longevity landscape today, there's not enough of what we're talking about.
Can we just stop there for a second?
Yeah.
So, I don't disagree with anything. I don't disagree with anything they said. I do think that there is a pragmatic component. Again, if you're sort of trained in the traditional reactive disease care culture, and you're trained that the only thing you're ever going to believe is a randomized, double-blind, placebo-controlled clinical trial on tens of thousands of people, which is kind of what they're saying. Like, that's what we need to do before we would ever consider recommending something for people. You are very constrained in what you can actually recommend. And in fact, I would bet at least some of the stuff that Eric Topol recommends has not gone through that level of scrutiny. So there's a little bit of, hypocrisy built into this stance as well. Sure, that's the gold standard. It would be great if we had the resources and people could do all that stuff and do it right, test everything. Even then, though, because of the complexities of human biology, human environment, you're going to get a very small set of things that work robustly across everyone, which is why, and I think Dr. Topol would agree with this, we need more ways to evaluate at the individual level what's working and what's not working. And I think we have some of those. We've got pretty good blood-based biomarkers for health. So why not use those? Why not use body composition? Why not use strength? Why not use VO2 max? Why not use blood chemistry to help us evaluate whether a particular regimen is working for someone or not? Even if we don't have the randomized double-blind placebo-controlled trial where we've tested all 12 things that a particular person is doing, right? Even if we don't have that data, I think we can get evidence in the real world for what's working, what might be working, what probably isn't working, and what's harmful. Obviously, it's a huge gray area of where you fall in terms of, again, what your tolerance for risk is, how you evaluate the risk reward for a given intervention. But I think the problem is this is black and white thinking, and we live in a gray world.
Okay, great. It sounds like the crux of the argument too is like maybe they feel medicine 3.0 is moving too fast, and then perhaps Peter and others feel like medicine 2.0 is moving too slow.
I think so.
And how do you find that balance?
I think you're right. I think that is the crux. And I personally very much believe that medicine 2.0 is moving too slow, or the transition is moving too slow. And I think, all we have to do is look at the current health status of people in America to have pretty good evidence that that's the case, right? People are certainly living longer than they were 50 years ago. And they are spending many, 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 many more years sick with chronic disease. Like that's just the data. So medicine 2.0 from that context has not worked. We need to change.
So, for example, for my patients over the age of 40, I calculate an ASCVD risk score, a 10-year score of them having a stroke or heart attack. And then from there, I can decide whether or not they're a good candidate for a statin or other modalities. So I remember vividly an episode of a TV program that I actually went to the premiere of with Chris Hemsworth and Peter Attia, where they told Chris Hemsworth that he had an elevated risk for Alzheimer's, and it drastically changed his worldview. I don't know if that's a good test, and I don't know if I would recommend that test for my patients, because outside of making healthy lifestyle changes, which I've been preaching to them before getting the results of that test, what changes finding out that you're high risk for a condition like that?
Well, I think for the right person, it can be a world of difference, because in general, we know about lifestyle factors. And I call it lifestyle plus, because it's not just diet, lots of details there, sleep, exercise, but it's all these other layers of data. It includes things like social isolation and nature, being out in nature, and environmental exposures. I mean, there's a long list and we can get into some of the details if you like. But the point is, most people don't go after all these things unless they have specificity about them. Then you can see, and I don't know the story about this fellow, but then you can say, I am doing everything I can to prevent this condition that I never want to get, that I'm at high risk for. So, but the point is, it's not just that. So firstly, now, used to be, you could only, until recently, you could only say you're at risk for Alzheimer's, but guess what? We can't tell you when. It could be when you're age 100, or it could be when you're 60. We can't tell you when. Now we can tell you when. That's very helpful. And
let's stop. So, I mean, again, I think everything that Dr. Topol has said here, I would agree with and is accurate. I think the premise of this question that, why would people want to know if they have, and in this case, they're talking about the ApoE allele, right? That's the specific genetic test that Chris Hemsworth had and was revealed. He was a homozygous, I think, for the ApoE4.
2 ApoE4s, yeah.
So, so I agree with Dr. Topol. For the right person, that can absolutely be a motivating factor to do everything you possibly can from a lifestyle perspective to reduce your risk of developing Alzheimer's disease. And in fact, we now know with some degree of confidence that for people who are ApoE4 homozygotes or ApoE4 carriers, you can in fact mitigate almost all, if not all, of that increased risk by adopting a healthy lifestyle. The other thing I'm surprised that because they're both, I think, cardiologists, I'm surprised that this wasn't part of the question. Having the ApoE4 allele also puts you at higher risk for heart disease. And we can do something about heart disease. So I think you would want to know if you are at higher risk for heart disease genetically, both because you can then do more screening early on and take steps from a medication perspective if you are in fact going down the road to developing heart disease. So I don't really understand the premise of this question. Again, this feels to me like a reactive disease care mindset. Like only somebody who has the reactive disease care mindset, I think, would ask, why would you want to know if you're at higher risk for a disease?
Yeah.
Information's power. Of course you'd want to know, at least from a medical provider perspective. I get that for some people individually, that may create more anxiety and they would not benefit from knowing, in fact, their risk. Mm-hmm. But I would think from a care provider perspective, you would want to know everything you can about that person, right? If in order to give you the best opportunity to care for them, care for their health going forward. Yeah. And the last thing I'll add, these guys probably won't like it, but it is true. There are now a couple of papers, they're small, so it's early, but there are now a couple of papers showing that in people who are ApoE4 carriers, so they're at higher risk for dementia, and you can detect early signs of dementia in the brain using MRI. So I'm going to use two things these guys apparently don't like. In these people, you can see early changes in the brain morphology and in cerebral blood flow that can be reversed with rapamycin treatment. Both of those. So increases in hippocampal and caudate nucleus volume, increases in cerebral blood flow in ApoE4 heterozygotes when they start taking rapamycin. Again, two small studies, so it's early, but if that turns out to be broadly true, this is a great example of why you would want to do the test, find out. You could then do the MRI, confirm that they are in fact showing early changes in brain structure, and then give them a drug, rapamycin, to reverse those early changes in brain structure. So to me, the premise of this question is sort of nonsensical. It's good to talk about it because I think people have this sort of idea that, I don't want to know. There's nothing I can do anyways. You do want to know, at least from a healthcare provider perspective. And yeah, there are things you can do.
Yep. I believe Dr. Mike's family medicine, by the way.
Okay.
Then he's a cardiologist. Another thing too is we've resonated a little bit because at Optispan, we do a lot of tests. And there's been times where like, hey, we do this test, but it doesn't change our behavior.
Right.
It doesn't change our testing, so we stop doing it.
Right.
We just wouldn't put ApoE in that.
No, and I would say the tests that we have stopped offering because they are not actionable also don't provide any useful information so far in terms of the sort of overall systems picture for an individual. Like the biological age tests, I'm put quotes around that. Biological age tests are a good example of this, right? So they're not actionable, and we now know that they are not very accurate, right? At least the direct-to-consumer ones. So we don't use those anymore.
Great. So I think we're good on this timestamp. Speaking of biological age, I'm going to backtrack a bit, and they actually do talk about biological age tests. So I want to get your opinion on that.
Tell me more about this biological clock, because I know Brian Johnson has frequently said his penis is 27 years old, his brain is 40 years old. I actually just used a scale that a company sent me, and it told me my biological metabolic age was 26 or something, even though I'm 35. Is this a validated way of measuring age? And is it easier to just look at your cholesterol, get a blood pressure cuff, and check those numbers, figuring out risk through that way, as opposed to calculating a biological age?
Yeah, so I don't think that getting these age metrics, so there's body-wide aging, and the main one that's been validated extensively is through the DNA methylation. It can be done through saliva. Ideally, you don't want to get it through a company because they have interest to make you younger and that you will send all your friends to get these tests and whatnot. But yeah, it's very accurate for your epigenetic age, which many will equate with a biologic age. But there's a lot of other tests that are being sold as giving you your biologic age that don't have a good validation.
Mm-hmm. So let's stop there.
Test, but the organ clock.
So he's half right. I mean, he's right in the sense that there are a lot of research studies that have used different epigenetic age algorithms. So there's not one, which he probably knows, but just sort of glossed over. So use different epigenetic age algorithms to correlate to either chronological age or disease risk or risk of dying. None of these things are correlated to biologic age. So again, just important to understand, biological age is correlated with your risk of dying or your risk of getting sick. These epigenetic tests are correlated with your risk of dying or your risk of getting sick or your chronological age. So it's a correlation to a correlation. Is not a measurement of anything other than where the specific epigenetic marks are. So it's an estimate of your, let's just say, health status. That's another place where this all gets kind of, mixed up. What we're really talking about is your health status or your risk of dying. So epigenetic tests have been used quite a bit in the research world. They have not really been validated I think the way that he's using the word validated in humans. And certainly there's no direct evidence that if you get an epigenetic test today, that can predict what's going to happen to you in the future. It's all sort of after the fact, right? Associations, correlations. And so then to say that the other things we can measure that are associated with health are not validated, maybe there haven't been as many papers for some of these things like facial aging or other blood-based biomarkers or other things you can measure that change with age. There are a lot of things that are really well validated, like VO2 max, really associated with mortality. Is that a biological age clock? I wouldn't call it that, but it fits the criteria for how they're using it.
You could sort of retroactively create one on any biomarker.
You could
right?
absolutely create, and people have, a variety of different biological age estimators based on functional metrics or clinical chemistry measures. And there are some. I've been involved with a couple of these studies, sort of, peripherally, where as a group, we have developed these biological age estimators based on a mix of blood-based markers and functional measures like VO2 max, grip strength, arm circumference, things that are measured in these human longevity studies. So the question I think still is, what combination of measures gives you the most accurate predictor of future health risks? That's what we're really interested in.
Yeah.
Current health status, future health risk.
Great. Yeah, I feel like The Onion should make a fake newsletter about the most ridiculous biological age clock you could do.
But I mean, I do think it's a problem because you'll see a lot of people in the space. In fact, I saw one on Instagram today by somebody who owns some longevity clinics, and they'll make false statements like, we can measure biological age today. We can't. But it's just a fact. That's a false statement. Now, maybe this person actually believes that because they don't understand what these tests are doing. That's a problem in my view if you're a big person in the longevity clinical space. But no, we cannot measure biological age. Full stop. That's just a fact.
If I was still a layman in this space, I'd probably fall into that because it's just there's a lot more noise there. in terms of like what you get picked up on.
The organ clocks are not out commercially.
That's not
yet.
true.
They were initially discovered.
Go ahead, you can keep going, but that's just not true.
Corey and colleagues. Now they've been validated by multiple groups and multiple large cohorts. And so they're going to be out there eventually, and that's 8 organs and your immune system. And they will be very valuable when they're available from a reputable laboratory, because they will tell us in a person at risk. So let's say your concern is Alzheimer's. What about your brain clock? Is it outpacing your chronologic actual age? And how does it stack up?
So let's just stop there. I don't think we need to go further with this one. Just a couple of things to say. So there are, in fact, organ-based epigenetic algorithms that are being marketed commercially. True Diagnostic has one. It's called Symphony Age. What he's referring to is just a different flavor of these organ functional assessments based on other things you can measure from blood that are correlated with organ function. And I agree with him. These tests will be likely to be extremely valuable in the research setting, in a medical setting, potentially in a clinical trial setting for stratifying people who are good candidates to go into a clinical trial. I worry that they're going to get rushed to the direct-to-consumer market. That's already happening. It will continue, and that will potentially create distrust or other questions around the validity of these things. But I do believe that a single blood test where you can get quantitative assessments of function across different tissues and organs is a really useful tool. The last thing to say, though, is we can sort of already do that, not from a single test, but we can measure heart function, kidney function, liver function, brain function, muscle function in different parts of the body. We know how to do that. So it's not like we're suddenly able to measure something we couldn't measure before. It's just easier because you can do it all potentially from a single sample that you get from blood.
Okay, I see.
I'm curious, as someone who's looking into tech in healthcare quite often, what's your take on the continuous glucose monitors? Because I have a lot of questions posed to me by patients who don't have either type 1 diabetes or type 2 diabetes who are interested in it. I've seen influencers, most popularly the Glucose Goddess. I don't know if you've heard of her.
Yes, I have. She's in the book.
Okay. She recommends everyone gets a glucometer in order to check the velocity or the rise of the spikes.
Yeah.
And for me, from my understanding, I have no idea what to do with that data, because when I look at someone's hemoglobin A1C, I know what to do. I look at someone's fasting blood sugar, I know what to do. When I look at their 2-hour postprandial, I know what to do. But when I look at a elevation post-meal, I don't know what to make with that data.
Okay, let's stop for a second right there. So I don't know how he's doing the 2-hour postprandial with his patients. I don't know if he's doing a true oral glucose tolerance test. But I think there's a couple of things I would say. One is, if he doesn't know what to do with the data and he's a doc, that's a problem. Sorry, you should know what to do with the data. 2, I don't think you can get anywhere near the same information from A1C and fasting glucose. So we all know A1C is a fairly crude marker of metabolic health. We use it because it's easy. We can measure it from blood. That's why. And it's cheap. Fasting glucose is exactly the same way. It's a crude marker of metabolic health. It works okay at the population level, but not very good. If you include fasting insulin too, then I think that's a little better, because then you can at least get a metric of insulin sensitivity. He didn't mention anything about insulin. The issue there is then the cost starts to stack up. Very few people, if they go to their primary care doc, are going to get a fasting insulin included in their annual blood draw. So we're using measures that are just not very precise or accurate to assess whether somebody is at risk for diabetes, pre-diabetic, or diabetic. So I think the information you get from a continuous glucose monitor is much more precise. I do think there are some problems, and I'm sure they'll get to what some of the challenges are, what some of the problems are in the space, and even among people who are using these things, what I would say properly in a clinical setting. It's not a perfect tool, but it is orders of magnitude better than A1C and fasting glucose. And any doc should know that if they've had any experience with these things.
Yeah, I didn't realize that fasting insulin wasn't on normal panels.
No,
Because you add those three together, you can get HOMA IR, which is pretty informative.
You can, although even there, for some people, right, your fasting values will not reflect your overall metabolic health. And that can happen in both directions, right? You can have people who have higher fasting values of glucose and insulin, yet are relatively metabolically healthy. And you can have people who have low fasting glucose and insulin who are metabolically unhealthy. So that works better across the population than only looking at A1C or only looking at fasting glucose, but you still miss a lot when you start talking about individuals. And again, if we're ever going to get to, really personalized healthcare, personalized health optimization, we got to start thinking about individuals. And even from a cost-effective perspective, my guess is if you look at a blood test for glucose, A1C, insulin, that's going to be comparable in expense to a continuous glucose monitor. You'll get much better, much higher quality data from CGM.
Assuming you know what to do with that data.
And I mean, again, it requires a little bit. You don't even necessarily have to know what the person ate, but you get a lot more information out of a CGM if you also know what the person ate. Great. The thing you miss from the CGM, of course, is you don't get insulin. So you can't calculate insulin sensitivity directly. I bet with AI tools, as we get more and more CGM data, we'll be able to estimate insulin sensitivity and overall metabolic health pretty well just from raw CGM data on an individual, even without knowing what they ate. That's my guess. We're not there yet.
Okay. All right.
Is there something that I'm missing here, or are people, again, putting cart before the horse?
Well, there's a lot there to unpack, Mike. So we recently did a big study where we got all the layers of data, including the glucose monitor, but the gut microbiome, the genome, everything they ate and drank, and their sleep, physical activity, because you need all these things to understand what is this spike from. Some people, they have no spikes. They can eat anything. Okay. And then others can get spikes 200 plus that are long in duration. And when you see a spike like that, that would say, there may be a higher risk of eventually developing type 2 diabetes. But I don't think these getting healthy people getting continuous glucose has much role except for, a couple weeks or maybe now that it's consumer available.
Yeah. Just health curiosity.
Yeah, curiosity. We don't know that the spikes, except for perhaps increased risk of diabetes. We have a paper coming out about that very soon.
That seems kind of important.
Does it have any risk increase for cancer, for Alzheimer's, for cardiovascular disease? We have no clue about that.
But increased risk of diabetes is a precursor to those three things.
Yeah,
right?
I mean, again, this is not proven. It is my intuition that metabolic dysfunction, which would mean increased risk of diabetes or prediabetes, accelerates the biological aging process. Certainly, correlatively is associated with higher risk for all of those things. But leaving all of that aside, continuous glucose monitors are only good for telling you if you have increased risk for diabetes. Well, yeah, that's good. That's important.
Because that's fuel on the fire of all the other things he said, right?
Well, not only that, but wouldn't you want to know?
Yeah,
I mean, come on.
Yeah. Here we go.
The studies need to be done. But one thing that's really, of course, fascinating, the work from Aaron Siegel in Israel and his colleagues, they did that brought in this whole field, is that if you and I ate the exact same thing, the exact same amount, the exact same time, one of us might have no spike and the other one could be, the 240. Mm-hmm. So we each are unique, and the same work was done with lipids.
So I think they're probably done with the CGM part. Just a couple things to add. I mean, I think they're right that it is very individual, and you can't tell much just from the height of the spike. What Dr. Topol said about the kinetics of the decrease in glucose. So you eat, let's say a banana, just to pick on bananas again. Yeah. You eat a banana, your glucose spikes, right? If you're metabolically healthy, it's going to come down within about an hour, right? Hour and a half at the outside. If you're metabolically unhealthy, what you might see is this sort of slow decline that he was talking about. And that's pretty indicative, right? So it's not so much how high the spike is. There probably is information there. I don't think we know enough about what actually causes the individual variation. And I just did an interview with Sean Gibbons about the microbiome. The microbiome is going to play a role in the height of that glucose spike as well. So, but there's probably some information about metabolic health in there as well. But you do definitely get an indication of whether somebody's metabolically healthy based on the kinetics of the overall kinetics of the glucose spike. The other thing these guys didn't talk about, though, is that, again, at least from my experience, both personally and from knowing lots of people who've used CGM, and we use it in our programs, is it's a really powerful educational and behavior modifying tool. Because when you see in real time your body react to a certain food in a specific way, or to exercise, right? Or to stress, you can't unlearn that. You're going to remember that the next time, you're tempted to have that bagel or that bowl of ice cream or that cake. You'll probably remember, oh yeah, this does something to my glucose that I don't really want to see happen again. So I think there's a behavior modifying component here that's quite powerful. But I also think, and I think this is where legitimately I get the pushback against the rush to consumer CGM, because I think, especially early on, the way these things were rolled out, it was not in combination with high quality education. So people got a lot of misinformation, like all glucose spikes are bad. You should never spike above whatever, 100. I mean, it's just nonsense. And so that led to, a lot of anxiety, a lot of fear around CGMs and how they were being interpreted. I think it needs to be paired with high quality education on what it means, individual variation, and why this tool is being used, and optimally to be used in the context of an overall health optimization program. I think in that context, they're really, really valuable.
Yeah, because without that, you might come to the conclusion flat equals good. So then you end up doing like a keto diet, no carbs, something like that.
Right, and then that may actually be bad for you based on other biomarkers if you aren't paying attention to those other biomarkers. That's right. The CGM in that case could be misleading.
Great.
Yeah, I see, and I'm curious what your feelings are on an opinion I've held for probably the last 10 years. I have this firm belief that healthcare is bad on two fronts. One, on the tail end of the low socioeconomic status. People can't get good healthcare because they don't have insurance, they're underinsured, can't pay for their medications. But also on the flip side, for the VIPs of the world who think they can buy good healthcare, they can buy shortcuts, they can demand antibiotics when they have a viral infection, they can demand propofol to go to sleep and end up having a terrible instance like with Michael Jackson. Do you see that happening in the world as well? And was that part of your impetus for talking about aging?
In my previous book, I actually pointed exactly what you're talking about, because most people just think about, it's the lower socioeconomic group that has problems with access and care. But there's the other side of it where it's too much medicine. So, for example, going out and getting total body MRIs with nothing substantiating it, right? And of course, as I go out in the book, a colleague here in New York, Drew Kular, a New Yorker journalist as well as a physician, he did this, and now he's got this whole prostate issue he's dealing with, and he's a young guy, and this is the problem when you get a test of thousands of dollars that doesn't have any evidence. It's heavily promoted. So what happens in the affluent that want to get more tests, and they're somehow getting convinced from entities that this is good to promote their health, they wind up getting these rabbit hole incidentalomas, and they could get biopsies because something was
so we could stop. I mean, we don't need to go down this path anymore. So I think this is true, right? It is true that when you get a preventative diagnostic, any preventative diagnostic, and by the way, this can happen on your annual blood work, sometimes you can get a false positive indication that there's a problem. And that can lead to additional tests that are invasive or create anxiety in order to rule out that false positive. That's true. The flip side of it is, if you don't get the diagnostic, you might miss something that you could catch early that you could fix before it becomes, a major problem or kills you. So it's always a balancing act. And so I think, again, it's legitimate to ask for whole body MRI who is appropriate to get that test. And you would want to think about things like underlying risk factors, which would include lifestyle. Are you a smoker? You might be at higher risk of cancer and want to get a whole body MRI, and age, right? there's no right or wrong answer here as to where you or how you do that algorithm of who do you choose gets a whole body MRI or any other preventative diagnostic. But I think the sort of the two extremes here, and it seems to me that Topol falls on one end of the extreme, although maybe I'm just reading that into this particular clip and he doesn't really hold this view, is that nobody should be getting preventative whole body MRIs. That's just stupid. I'm sorry, it's just dumb. Of course people should be getting preventative whole body MRIs. The question is who, and we can have a discussion about that. Also, the other end of the stream is everybody should be getting them. There's no good reason to believe that's true either. And in fact, we know there are some people where it will cause a lot of anxiety and be detrimental to their health for that reason. So I think it would be better to have a conversation to actually try to come up with some consensus around where is this the right thing to do and where is it getting too far. Again, I totally get their pushback, and I struggle with the direct-to-consumer marketing of diagnostics, just like I struggle with the direct-to-consumer marketing of supplements, right? The incentives there are to push to get more and more and more and more and more people to use these diagnostics, because that's what these direct-to-consumer companies, that's how they make their money. I would also say this is true in the out-of-pocket concierge medicine world, where you see a lot of concierge docs or longevity docs offering diagnostics or other procedures with a markup. So come in and get this procedure done. The doc pays $400 for that, and then they mark it up another $1,000, right? Yeah. So that's an incentive structure that incentivizes medical providers to sell things that people don't need. That's just a problem with the way our system is structured. And it's, medicine 2.0 is unfortunately too slow to adopt these things. And I think what we're seeing is in medicine 3.0, unfortunately, there are now incentives moving in that are causing people to do things that are not in the best interests of their clients or their customers in the direct-to-consumer space by over-marketing some of these things. The true answer is somewhere in the middle. But this idea that it's all or nothing, it's unfortunate to me that, again, people like Eric Topol, who I'm sure if I sat down with him, we would have a much different conversation than what he's having here. Will say things that make it seem as though they're coming from the perspective that nobody should be doing this, right? The answer is obviously somewhere in the middle.
I've got a lot of half-baked thoughts I want to run by you. So one of them is just like thinking of a spectrum of body composition. You have most scalable, lowest, cost would be BMI. So height and weight.
Sure.
On the other end, you have maybe a full MRI for body comp. You have like DEXA and in-body somewhere in the middle.
Yeah, but MRI gives you a lot of. So what he's picking on is the other stuff that MRI
for sure
does, right?
Yeah, but just in this sort of spectrum, DEXA's here, MRI's here, whatever. I feel like what they're saying is because most people can afford here, that some people can afford here. Like, where do you draw the line on who gets what services?
No, maybe that's part of what they're getting at, but I think what they're saying is that definitely people who have at the lower end of the socioeconomic spectrum get lower quality healthcare than average, right?
Yeah.
I think what they're suggesting, and this is the other point I wanted to make, is that people at the very high end of the socioeconomic status are also getting lower quality healthcare, but it's because they're being offered too much, right?
Prescription,
over-diagnosed, over-prescription, whatever.
Okay.
That's an interesting idea. I would love to see somebody actually show me some data. Yeah. I think if we look at the data, what we see is that people at the high end of the socioeconomic status scale live longer and tend to be healthier into old age. So yeah, are there rare one-offs where somebody like Michael Jackson is able to get access to something that they die from? Sure, there are those rare one-offs, but if we look on average, it seems as though there's no evidence to support the idea that people who are at the highest end of the socioeconomic status scale are getting lower quality healthcare because they're getting whole body MRIs, right? So I don't think there's any good evidence to support that. It's kind of a nice, that's nice, it's an interesting idea, and maybe in some cases that's true. I'm very doubtful that's true sort of on whole.
Okay. I watched a decent amount of Dr. Mike, and I watched his interview with Scott Carney, who we had on the show, and it seems like, I'm sort of paraphrasing him, it seems like he's a believer that you can't just throw money at health, and that people like Brian Johnson is a bad example of someone who's trying to throw a lot of money in diagnostics to improve health.
Well, I would reframe that. I mean, that's true. So you can throw money at health, and you can get access to better healthcare, no question about it. And look, that's a problem. Like that sucks. Like I'm not for that.
Yeah,
it's just the reality of the situation. You can indeed throw money at health. But I think like anything else, you can throw money at a problem in smart ways or stupid ways, right? You can waste money thinking that you're throwing money at health, but it's really not doing anything for you.
Yeah.
You can, of course, throw a lot of money at your health and also take it too far in other ways, right? That are going to be ultimately detrimental, right? So there's a lot of nuance here, right? It is the case for sure that just because you spend more money on your health doesn't necessarily mean you're going to live longer and be healthier. But also, if you allocate resources in an intelligent way toward a problem, you are going to get better outcomes than if you don't allocate resources towards that problem, right?
Yeah.
It's kind of obvious.
Yeah, great. I think that's well said. So that's all the timestamps I had for you.
Okay.
So.
I mean, I think this was interesting. You know, I think it also sort of, again, points to how varied the viewpoints are on, you know, where we should land from completely reactive. And I don't mean to suggest that Eric Topol or Dr. Mike are completely reactive. Like they're not. They're somewhere in the middle. But there's a spectrum of people who have been indoctrinated in this culture of do no harm, do nothing until somebody's sick, and then try to fix the problem, right? To do everything we can, get as much data as we possibly can on people, irregardless of how much it costs or how invasive it is, to catch things early, right? That would be the other end of the extreme.
Yeah.
Of course, the optimal answer is somewhere in the middle. And I think it's interesting to see where people fall and how it influences their perspectives. Again, I guess my other take-home message would be, and nobody's perfect at this, but I think we should all really try hard not to make blanket statements where there is no right or wrong, or we don't know the answer yet, right? And to be more precise in our language and say, okay, here's what the data say, and here's my interpretation, you know, versus whole body MRI is bad, rapamycin bad, right? I mean, I think we would all benefit from a little bit more precision and nuance in our conversations around these topics.
Yeah, great. Well said. I mean, again, after watching a lot of Dr. Mike, I feel like Pareto principle somewhere. I think he really believes in that sort of like, what's the 80% that actually matters? I think he kind of throws out the other 20% in his mind. The one quote this person said in the comment here is perfect is the enemy of good is something Dr. Mike kind of says a lot as well.
Well, I mean, that's an interesting thing, right? Perfect is the enemy of good. Sure. You could put, should we be taking rapamycin off label right under that, right? I mean, again, this is where the hypocrisy of the thinking, I think, comes into play. You know, we don't have randomized, double-blind, placebo-controlled clinical trials proving that rapamycin slows aging in people, in tens of thousands of people. Therefore, nobody should be taking it off label. That's a perfect example of perfect is the enemy of good enough.
Yeah, there we go. All right. There's a few comments that people talk about something that we already talked about, which is like the correlation between protein intake and atherosclerosis. And lastly, I want to end on this one, which made me laugh, which is can't believe Dr. Mike got an interview with Harrison Ford. Before I even read that comment, I was like, this guy looks like Harrison
I never
Ford.
made that connection.
Oh, yeah, you'll see it now. So, right. Well, thanks, Matt. That was fun.
Thank you. Yeah. Hey, everyone. Hope you liked this episode of the Optispan podcast. As always, please leave your comments or questions below. And we hope to see you next time on the podcast.